there's no respiratory failure, there's no mechanical ventilation. Okay. The mechanical ventilation started off after the oil pandemic. Historically, they used to have ventilators in the ORs before the 50s. They were really primitive. Oil pandemic came on board in 39 or something like that. And, they relied predominantly on the students back to survive and realized that maybe we should automate it. As they made automated it to half. And in the past 10, maybe 20 years, there's been a lot of development into different kinds of noise. And your list keeps growing, but it's really useless. Useless as far as a list. You have to just understand the basic physiology behind what you're trying to do and kind of try to adapt whatever they have. But in reality, the basics are the basics. And how do you monitor them? We're only gonna stop at here today, and then later on, like next session, we'll cover the rest of it. How do we breathe? There's a brain. Brain sends a signal to the spinal cord, from the spinal cord to the nerves, to the chest wall, and the combination of the chest wall, the muscles, and the diaphragm obey what the brain says and kind of contract them. As they contract, they create negative pressure inside the thorax. As they do that, air capacity goes in. And then when you X-ray, you X-ray passively, unless there's like a pathology, and we X-ray with that shape. What happens in the lung is air goes into the alveolar spaces. There's a mesh of blood vessels around each alveolar unit, and that mesh of blood is in continuous gas exchange between air and the capillaries. During the period that the blood is there and breath is being taken, oxygen gets exchanged, and then it goes through the bloodstream through the circulation. So you have a certain load that you're breathing through, and that is determined by the compliance of your respiratory system, your resistance, and what kind of ventilation your body needs based on your acid-base status, based on the size of your body, etc. And then the chest and lungs act like a bellows, it inflates and deflates, and it truly depends on how good the respiratory drive is, whether you have a decent neurotransmission, and whether you have a good muscle strength in order to do that. If that's the normal ventilation you can imagine, where the failure can occur, and it can happen at several levels. But if you divide them into two concepts, there are only two different kinds of respiratory. And then there's the attitude of failure of the airway, or scared of protecting the airway. There is a failure of the airway anatomically, and that's a new phenomenon. You need to establish an airway, you don't necessarily need to establish a ventilator. But in reality, there are two different kinds of failure. There's the failure to ventilate, and then there's failure to oxygenate. If you talk about failure to ventilate, you're predominantly talking about neurological abnormalities, starting from the respiratory center, phrenic nerve, neuromuscular junction, muscles, including the diaphragm, or the diaphragm is the largest muscle of breathing. Additionally, so all of these neurological abnormalities can occur with and without other problems, which include the muscular, not muscular, the skeleton of the chest. Like if you have somebody with a plain chest, for example, they may end up in trouble. If you have some pleural disease with a lot of pleural effusion, it may impact your ability to ventilate. And the one thing that everybody tends to forget is the extra pulmonary and respiratory abnormalities. So whenever you have somebody with a significant abdominal hypertension, the diaphragm stops working at some point in time, people will end up in respiratory. So that is the way to ventilate people with these disorders is what you focus on. Usually, they go into ventilatory failure with increase in PCO2. And there's another problem that will occur when you have failure to oxygenate, and that's basically 4 or 5 mechanisms that you know about, perhaps 6 of them. The most common of which in the ICU is ventilation perfusion mismatch, followed by shunting, and people who have significant airway abnormality airway and parenchymal abnormality, that space will increase. And if that were the case, you have a combination of hypoxia as well as hypercapnia. Diffusion abnormalities, you have extensive interstitial lung disease, for example, or acute interstitial abnormalities like we've seen before a lot, you will end up with the oxygenation failure as well. The two that are not here, the one that will never be here is altitude, because we are living at sea level, close to sea level. And the second one, which is always unthought of, is the reduced cardiac output one. So whenever you have a very low cardiac output, your mixed units return oxygenation becomes very low. So the SCVO2 decreases significantly. So when that happens, the return to the lung is significantly hypoxic, that you're not going to be able to oxygenate very well. Those are situations where like somebody on the floor, or they're desaturating, and then you look at their blood pressure is nothing. So it's usually the circulation that made the hypoxia worse, and you would never be able to correct it until you correct the circulation. So with that said, you can simply physiologically look at parameters that makes you want to think of what do I want to correct. So from a pathophysiologic standpoint, you can think about it in 4 different terms. You can think about it in the term of airway resistance increase, and that's where practically your COPD, asthma live, or to a lesser degree, the larger airway abnormalities. After all, when you look at what makes the resistance in the respiratory system, it's actually the smaller airways, not the larger airways. The larger airways becomes a problem as far as your ability to deliver breaths. Like, let's say you have somebody who take a mask, for example, and you intubate them before you do any maneuvers, you're going to have some difficulty ventilating them because of the obstruction that you're seeing. So this you have to keep in mind. The ventilation perfusion abnormalities, as we talked about, and there are conditions that decrease the compliance of the respiratory system. And those are predominantly lung-related. Predominantly, I'd say, because sometimes you have compliance issues related to chest wall abnormalities, like that would happen with pleural disease, as well as abdominal disease. If that were the case, you're going to have a hard time delivering the breath with adequate pressures. The fourth category is related to the body itself. If you have a high load with big acid, that your demands on your respiratory system will increase. The DKA, when you have to really ventilate with very high minute ventilation, that will make you fatigue fast. Conditions that will increase your carbon dioxide production, like seizures, very rigors that you're unable to do, toxicity from anything that gives you very high temperatures, things like malignant hypothermia, things like serotonin toxicity, serotonin syndrome, I mean, with some overdoses, and conditions that increase your oxygen consumption, which are similar to what I just said. So these conditions will increase your minute ventilation. Over time, as you increase your minute ventilation, the work of breathing in general will increase, and over time, if you don't pay attention to it, you will end up with fatigue, and with fatigue will lead to hypercapnia. Hypercapnia and hypoxia go hand in hand. If you only have hypercapnia and hypoxia, will preserve AA gradient, and it's pure ventilation abnormality if you focus on and you ignore the oxygen. Though remember that almost always, when you have respiratory fatigue, you're going to have some degree of atelectasis. So the lung will have some issues with it. If you're starting with ventilation perfusion abnormalities, same thing, you're going to end up with increased work of breathing right away, with or without increase in ventilation. Fatigue will follow. Obviously, with changes in ventilation perfusion matching, you're going to end up with hypoxia that will also, as when you have significant hypoxia over time, the perfusion to your respiratory muscles is going to jump. And as that happens, fatigue will occur, or hypercapnia will follow. So this is the basically how you think of respiratory failure and where the problems are in order to focus on whether I need to ventilate a little bit more or I want to oxygenate a little bit more. I want backwards. Why isn't this on the slide? Hey, you guys, can you see?
Yeah, we
Yes.
can see.
Yeah, we can.
Very good. Shunting in particular, remember when you have a big shunt, and that's what you're going to observe a lot in people who have ARDS and lung collapses, you can estimate the degree of shunt by applying 100% oxygen and figure out what happens to your partial pressure of oxygen. So when you have the normal shunt fracture, which is less than 10%, you apply oxygen will increase. When you have 50% shunt, whatever you apply doesn't go anywhere. This is associated with 100% mortality. Now that doesn't mean that you don't try to decrease the shunt by certain maneuvers on the ventilator, but that's to be kept in mind. This is redundant, I believe, at university hospitals, because you see, when you look at how do you define hypoxic respiratory failure or hypoxic respiratory failure, there's a lot of argument about what is the right value. So here we agree that if you're talking about hypoxic respiratory failure, if it's acute, you're talking about less than 60 PO2 on the room air, or a saturation that's less than 91%. Your PF ratio, PO2 to FiO2 ratio less than 300. In the chronic basis, pretty much the same thing. Acute on chronic, there has to be a change in your PO2. In hypercapnia, you're talking about PCO2 is greater than 50 with low pH if acute, normal pH if chronic, and if it's acute on chronic, there's a change of more than 10 from baseline with a reduction in diffusion capacity. This is a kind of an algorithm of what to expect when you put a FiO2, and that's, I will share these slides with you later on once I finish the second one. Minute ventilation, the higher the minute ventilation, the lower your PCO2 will get. When your minute ventilation becomes very low, like when somebody gets sedated, they're breathing at about 8 liters per minute, and all of a sudden you sedate them to 5 liters per minute, you have a very, very minor change. If you drop to 4.5, your PCO2 will go very high. It's not a linear graph, it's a hyperbolic graph. So keep that in mind, that when people are small and you're trying to ventilate them, pay attention to the amount of minute ventilation with the ventilator. And always try to give them a reserve so that they don't really massively change their PCO2. The oxygen is not as scientific as carbon dioxide output. You have a very clear idea of what determines your PCO2. If you remember your medicine 101, minute ventilation is equal to alveolar ventilation plus your dead space. The alveolar ventilation, the lower it is, the higher your PCO2 will get. And you can kind of arrange things around and kind of play with the mathematics a little bit. And your PaCO2, which is arterial PaCO2, is equal to your alveolar CO2, and it's equal to a constant multiplied by the amount of carbon dioxide that you produce, and inversely proportional to the alveolar ventilation. Knowing what your alveolar ventilation is, you plug it in, and the causes of hypercapnia can be divided into the 3 components. It is very unusual to have an increase in carbon dioxide production as the sole cause of CO2 retention, unless you have somebody who has pre-existing muscle disease and kind of a little bit of a baseline, and then all of a sudden they have a fever, and they with that higher PCO2 that they got, they put their respiratory system cannot accommodate them, and they end up with a much higher CO2. So carbon dioxide production by itself is not. It, in combination with the other factors, will cause some CO2 increase. And so when you're thinking about this, and let's say you have somebody with obstructive lung disease, you want to work your best at reducing that space at the time rather than increasing their respiratory. You have somebody who has intoxication with Valium, they breathing 6 times a minute, and that's the cause of their hypercapnia. You focus on increasing their respiratory, and that's the importance of looking at what's the cause, what's the lead cause of CO2 retention. This is very important to remember your respiratory mechanics. Whenever you are breathing, think of the lung as a unit inside a box, and that box can tube the person's in it, and air gets into the tubing. That tubing is dynamic, the chest wall and everything is dynamic, but in the schematic view, the air flows in, and for it to flow in, it has to overcome the resistance, of the respiratory system, and afterwards it has to overcome the resistance that is in the lung itself. So you would think about it as the resistive forces that are responsible for the trans-airway pressures, and then there are resistive forces that are to bypass the trans-thoracic pressures. And the entire thing is referred to as the trans-respiratory pressure. And if you really want to calculate the trans-respiratory pressure, it's the pressure at the oral cavity of the tubing, when the flow is ceasing, minus body surface area. That's the difference between them. So in positive pressure breathing, the airway pressure is positive, and the atmospheric pressure is normalized at 0. So that's how air will flow in. In negative pressure ventilation, the airway pressure is still higher in a negative way in comparison to the atmosphere. That's why air will flow in by forcing it through it. Now, so resistance, when you're thinking about how air flows through a resistor, it is nothing but the change in pressure over the change in flow. And when you think about when you are in stem, all the tissues in the lung and the chest wall, you have to think about it as I have to overcome a certain elastance, and that's nothing but the reciprocal of the compliance. So when you say a lung is stiff, means that its elastance is very high, or its compliance is very low. So always keep that in mind. And whenever you are thinking of how do you, what's the amount of work that a person has to give, it's nothing but the product of pressure and volume. That's why you plot it in the pressure volume curve, and you end up with kind of a simplicity curve, which is inspiration. And the way you want to keep your lung at is somewhere in the middle of this graph. You don't want to leave it at this end, and you don't want to leave it at this end. Because if you leave it at this end, the resistance is very high, and if you really want to leave it at this end, the resistance is very high as well. So the more inflated the lung, the stiffer it gets, the more small the lung is, the stiffer it gets. So as well as the airway resistance. So the airway resistance, so the graph for the airway resistance. Sorry guys, you are not here. You're not gonna see my Picasso. So when you're plotting the volume of this resistance, airway resistance, it's like something like that. And at FRC it's at its best. At FRC, sorry. It's the lowest resistance. Good. Mechanical ventilation delivers gas to the lungs using positive pressure at a certain rate. The amount of gas delivered can be limited by time, pressure, or volume. And the duration can be cycled by time, pressure, or flow. And it is really not a treatment of it. It is just a supportive tool waiting for you to treat the underlying condition. If you think about ventilation as a treatment option, fail. It's just a supportive tool. This is the number of modes that have been reported in the literature. And in reality, each company that makes a ventilator wants to sell you that this is the best thing ever. Bottom line, no comparison. So you cannot say which mode is better than the other. No mode say which ventilator is better than the other. Whatever ventilator you end up using, for us here it's Vega and the VA, I forgot what they have here. Servos. So servos are made machine. Ours are pretty good as well. But anyway, whatever you learn, think on basis of physiology and think of how the breath is being given. Before we start that, whenever you decide somebody has respiratory failure, you need to assist on the first question you have to ask yourself, do I do it non-invasively or do I do it invasively? If I decide to do it non-invasively, if you decide to do it non-invasively, you have to make sure you don't have a contraindication. You have a mental status to work with, you have a face to use it with, you have a proper patient, you don't have an aspiration risk, and you don't have somebody who's going to be on the ventilator for days on end because you can be there at ARDS. Like it's a common sense basically. If you have that and if you have no contraindication, you apply it. If it works, great. If it doesn't work, you have to go to mechanical ventilation. And the minute you go into mechanical ventilation, you establish an airway. And as you establish an airway, you can go into whatever mode you want to go into. The most common, and for this part of the talk, we're going to focus on the assist control, SIMD, pressure support. The other modalities we'll talk about next time. The goals are correct gas exchange, but more important is to decrease the work of bleeding. You want to make sure the patient is comfortable. You want to make sure that the muscles are resting and they are not fatiguing. You want to prevent whatever apparatus the patient was doing by themselves. You want to decrease that required oxygen consumption. You do not want to increase the load of the heart. So you want to use the ventilator as your helper for a heart patient. And if you are using neuromuscular blockade and you want to try your best to improve your lung compliance. Unfortunately, the majority of people focus here. And that's what the residents focus on a lot. What I need you guys to is focus down here. And that's what you do when you examine patients on ventilators. So if you think about this, in addition to all of these goals, you want to use it in a safe way, avoiding ventilator-induced lung injury. You have to set goals in your mind. Like I want to make sure that I have an acceptable pH and acceptable PCO2 based on the patient. So if you have somebody who's normal rather than ill, you want to aim towards normal. If you have somebody with chronic CO2 retention who lives with PCO2 of 70, you don't want the ventilator to get down to 60 because it will take forever to get that down. So you have to have a set goal in mind. Regardless of what set goal you want to make sure it's safe. Meaning the plateau pressure, which is the alveolar pressure, setting of the alveolar pressure, is below 30 because above that it's associated with viral trauma. You want to make sure that you don't have autopsy or you don't want to have any significant autopsy to interfere with the cardiac output. Because if you do, you end up with hemodynamic instability. You want to maintain an adequate oxygenation. 88 has been reported for by RSNet, though there's more data now to say we should be 94 and 96%. FiO2 should be less than 60 because in animal models above that you end up with oxygen toxicity, and you want to make sure you have an adequate delivery of oxygen, meaning you don't want the ventilator to decrease your cardiac output because the others are kind of part of oxygenation. In ARDS, there are special situations, and COPD there are special situations we'll talk about tomorrow. Not tomorrow, or never, right? Definitions. You need to know this. Spontaneous is when the patient is in control of both the start and stopping of every breath that they take. A mandatory breath is a machine-delivered breath that either starts or stops based on a certain amount of gas that's delivered based on your setup. The trigger is when the inspiration starts. Cycling is when the inspiration stops. Good. An assisted breath is actually a ventilated breath that was initiated by someone with the patient. Airway pressure rises above a certain baseline. Volume control is when the ventilator will deliver a certain preset volume, and all the rest becomes dependent. And the pressure control is when you decide on the pressure, and then the tidal volume becomes your dependent variable. And mode is a pattern of breath that's delivered by ventilation. It can be a pressure support, which means that after the patient initiates a certain flow, the ventilator will rise its pressure. Once that flow is decreased to a certain level, the ventilator stops. Pressure control, regardless what the patient does, the ventilator is going to give a certain pressure. And the volume control is when the volume is whatever volume you ask the ventilator to give, it will keep on giving it until it's done. To understand the differences, you need to kind of go back to the actual breath and how it's looking at the flow is very important. The positive deflection is the inspiration, and the negative deflection is the expiration. Patient triggered is at point A, then it gets assisted, so that the ventilator starts, and this setting is giving a Rana kind of a flow assistance, and then at C it cycles off because the beginning of exhalation is going to happen. Cycling can either be time related, saying that okay, stop giving blood at a certain time, or it can be actually giving a certain volume, or actually giving a certain pressure support flow basically.
So for the cycling, those are inherent to those various modes. So you can have like a flow cycle breath on a pressure control.
No, it depends on how you decide.
Okay.
It depends on how you decide it. So you, the flow, the majority of the modern ventilators at this point in time adjust flow by adjusting time. So you remember that the flow is nothing but volume divided by time, right? So if you decide on a pressure control, you decide on a certain time frame to give the right pressure breath through, and by doing so, the flow will be determined, and depending on the compliance of the system, the volume will be dependent on. And these are the most commonly used modes, but actually with the newer ventilators, everybody is doing hybrid. This is why it's becoming that graph over here is still applicable, but how to set it up, it's being set up by the combination of pressure regulation to guarantee a certain breath to be given. Like let's see that PRDC is pressure regulated volume control, which means that on every breath by breath basis, the machine determines the compliance of the respiratory system, and according to that compliance, delivers the breath based on the least amount of pressure possible. If the respiratory compliance changes, the ventilator itself will regulate its pressure upwards in order to get whatever volume you decide to give. At the VA, I think Servo calls it PRDC. Over here, they call it autoflow. Drager, they call it autoflow. Other companies, they call it either VC plus. And then there's one machine that calls it bi-level or something like that. So depends. So this is why the most I told you, many of them are equivalent. So for us, it's autoflow, and the problem with that is respiratory therapy always puts people on autoflow. Supposedly, it's the most optimal for patients. But if the patient is agitated and they're working hard there, the ventilator will, let's say they're agitated and keep on trying to do stuff, the ventilator will sense that because of the negative pressure the patient is doing and delivers less support. So over time, the patient will fatigue up. And because if they are doing more, they can overcome the volume that you set it at, and you end up with much bigger tidal volume that you want the patient to get. So I'll talk a bit about this tomorrow. So in the volume control, you see something like this. And whenever you go to the ventilator, you need to look at the scalars, which will show you the pressure, the flow, and the volume. The least important perhaps is the volume, unless it's changing too much and then you end up with a problem. But focus on the flow and focus on what's happening with the pressure waveform. So this person, every single breath that they're taking, at the initiation of the inspiration, the pressure is below the baseline, which means every breath here is being assisted by the patient. This is a flow being given as a decelerating mode. There are two ways to give the breath. You have a constant flow or a decelerating flow. So it starts high and goes down. So this person is getting a decelerating waveform, basically. Inspiration, expiration. And you can, use basically what it is. Now, if you start to see irregularities, then you need to start to think of what kind of syncopated I have in order to go and adjust the regulator accordingly, which I will talk about later next time. On a volume controlled ventilation, you can use it as an AC or a SINV or pressure support. Meaning, so how do you set it? You give somebody a certain FiO2, you determine what type of volume, you determine the respiratory rate, and you can determine the flow rate of the majority of time nowadays, or something I time, so that the flow will be determined based on whatever time you decided. Flow profile, this is associated with whenever you're giving a square waveform, the pressure will be much higher and it will ramp up. Because the flow is constant, and the pressure will be like this. And it will be much faster breath. But the price that you pay is a higher peak pressure. So in COPDers, we want a very low expiratory time to give them a bigger expiratory time. It is not a bad idea to do that. However, you have to remember how high the pressure is rising. So you don't want to do it in a dangerous zone. The decelerating mode is the most commonly used because with the most commonly used, it's kind of because it starts high and then slows down. So it takes you a little bit longer to deliver the amount of volume that you want to deliver. But the advantage is you don't have very high pressures. It's just a stable and a kind of constant pressure zone. And then you decide on the peak, and the peak is a different story. You do this, and these are your goals. And actually, every time you put something on the ventilator, you set the goals in your head. This is what you want to achieve. For target volume, although the 6 cc's per kilogram is what we have been recording it for a long time, last week or 2 weeks ago, in the blue journal or the annals, actually, annals already adds quite a total dose, but 6 cc's is not going to work. What you have to do is decide whether 6 cc's is right to do. That's because you have to look at the 6 cc's in relationship to what the compliance of the lung is doing. So if you're put at 6 cc's and your compliance is still very low and you're still in an injurious pattern, you have to decrease the 6 cc's. So that 6 is not something to fit for all. 6 is a good target, but the target should be what's happening with the lung itself, not necessarily the 6 cc's per kilo. Anyway, we'll talk about this when we talk about the areas. And then you calculate it for based on the weight of the people. And the one thing you have to always remember, people with muscular disease are almost always very hungry. So when you use very low calorie foods, they can't tolerate it. They just want much bigger volumes. Monitoring peak and plateau pressure is very important. Monitoring airway resistance is very important. And the reason for this is, remember, when we're giving the breath, as we're giving it through, if we were to put an inspiratory hold, there would be, if you give the breath and upon giving the breath, you don't allow the patient to exhale, just put a hold on it, you would get what we refer to as a plateau pressure, and that's nothing but the alveolar pressure. There's no more flow. So whatever is in the beginning of the tube is equal to whatever the end of the tube, as long as there is no obstruction in the middle. So if that's the case, then this part of the pressure was needed to overcome the airway resistance, and this part of the pressure was needed to overcome the resistant forces from the poor compliance of whatever compliance the respiratory system has. This is just a reminder of what we said earlier about elastance and resistance. And every time you're adjusting the ventilator, particularly when it comes to PEEP, keep in mind that you will be able to impact this difference, which is referred to as the driving pressure. So the smaller the driving pressure is, the better the compliance you will achieve with the ventilator. Meaning you were able to include parts of the wall into the equation. So in adjusting the ventilator, as you adjust everything, you sit there and you start dialing up by very small increments. Every time you dial it up, you sit there for like about 5-10 breaths, and you calculate your driving pressure. If the driving pressure is still decreasing, then you keep on doing it. Now, at some point, as you increase peak further, there will be no change or slight increase. And at that time, we know that you reached your highest distension in the lung, and you go backwards one step behind. After all, at least in the ARDS literature, if you are able to achieve a driving pressure that is below 15, it is associated with better survival. So conditions that will increase the peak-to-peak plateau is related to the difference between peak plateau as it increases its resistance. Think of these categories. Kinking the tube has a plug in it, etc., etc. Conditions that unchanged or decrease, you end up with a little bit of these phenomena. That's fine. Now, in pressure control ventilation, the dependent variable is going to be the volume. So if your compliance of respiratory system drops for the same pressure that you have, the amount of volume you're going to be getting is much lower. And the same thing, that but the pressure becomes a very constant pressure. And the time, this is the entire respiratory cycle. We have time for inspiration, time for exhalation as the moment goes on. In pressure control, what you said is the amount of oxygen, whatever driving pressure you want to give, respiratory, I-to-E ratio, or respiratory time. You can't set the three together. It's just 2 out of 3 because the third one becomes a calculated phenomenon. And the same thing for the flow part of gas. You can either use the square wave, the square wave, or the sinusoidal. To be honest with you, sinusoidal, I've never, I don't know why it's better. If it is better, I've tried it several times, doesn't make any difference. It's very similar to decelerated movement. I have to read about it. This is how you calculate the I-to-E ratio, whatever you're setting in I time. And I think let's stop here because we're going to go into a little bit of more monitoring stuff for the next 4 questions. Questions? Happy, unhappy, useless, not useless, basic, too basic.
No, we need a fence. We do it without the investment. Like,
Oh, we do a little bit. That's something you have plenty of time to do that.
yeah.
Your time's up, actually. But you don't have enough time. Okay?
I know.
It's great for you. No, seriously, guys.
It's a lot easier with the vent, seriously, because then you can touch and see things.
We do it.
I know that kind of the general principle, whatever ventilator mode, achieves all of your goals is the best one for the patient in the situation. Is there kind of, but you choose something, you intubate, the patient's intubated, you choose something. Do you kind of have some go-tos based on, patient situations? I mean, you start with something. So,
Yes. So it depends on the situation that you're talking about. Actually, next time we'll have some examples. Like if you're on ARDS, you have COPD or asthmatic or something resistant pneumonia, that's how to set it up. If you're asking what would be the first word to use on, our respiratory therapists here have a culture of volume cycle medication. So the first that they go to is that. And according to what you achieve with it, often, particularly in the LBS, you're going to end up with very high peak pressures and you cannot really deal with them. And after you sedate the patient with paralyzing whatever, if you still have high pressures, majority of us will switch to pressure control ventilation and then we start going that way. There are, for ARDS in particular, there is the newer modality, it's not new anymore, it's like APRD, where you have like your arc trapping there in the lung. And that would be in somebody who's awake, alert, and willing to cooperate with me. This is the first one that I would go to. In ARDS, in asthmatics, the least pressure would be better. I couldn't care less about this. I just want to achieve the least pressure possible. So if you intubated an asthmatic, almost always you end up paralyzing an asthmatic if the volume that you're giving, which is like usually 6 or less per kilo, still is giving too high peak pressures, you switch to pressure control and tolerate the tachypnea and adjust. So truly it's situational. As long as you keep in mind the physiology behind what you do, and if your respiratory therapist has no clue how to set up a pressure control or get pressure control, what are you comfortable with? How can you do that? You set it in a way that you will keep it not dangerous. You know? The work of breathing, perhaps, if you were to go by pressure volume curves, would be a little bit less with pressure control ventilation. But that is a so some people have used it predominantly in on if you are going to be on a ventilator for a short period of time, so you don't fatigue them. But those people are post-op with normal lungs, you know, so they can do whatever they want.
Sure.
Pressure support mode, like if you have somebody who has everything is intact and has on a ventilator or something that's nothing to do with lung disease, like somebody with diabetes, for example, or a very severe respiratory alkalosis, you may need to use pressure support because the ventilator is making them more alkalotic, or you just had something like this again. And just pressure support for small amounts, you don't get any support for minimal any support from the ventilator. That's how we do it. And then
So, sorry, for pressure support, so